Chapter 5, Video 2. Today we're going to talk about the gastrostomy or the jejunostomy tube. First, the gastrostomy tube is inserted into the stomach through a surgical opening in the abdomen. A percutaneous endoscopic gastrostomy tube. This is also known as a PEG tube because of the name percutaneous endoscopic gastrostomy. So this gastrostomy tube is a PEG tube. It goes in through the abdomen directly into the stomach, okay? And then the jejunostomy tube is inserted into the jejunum part of the small intestine through a surgically made opening in the abdomen. So know the difference here. You may see the tube going through the abdomen, but knowing the placement is important as to knowing which one is which. So the PEG tube is into the stomach. The jejunostomy tube is actually in the small intestine. These tubes are used in a person who will require nutritional support for longer than a few weeks. They may have these tubes in place for months or even years. One thing, too, we need to make sure that we check this site for redness and drainage. We may see a little bit of mucus around this site, and that can be cleaned off with some mild soap and water and rinsed. But we just want to make sure that the skin is not red and becoming infected and not breaking down. So, and I will show you guys in lab how to care for a PEG tube site. It's really simple. The main thing we do is we just keep it clean. We can put a gauze around the tube site to help absorb some of the drainage and protect the skin. So we just need to make sure that we're keeping it clean and keeping that skin protected. There are 3 different ways of administering enteral nutrition. Now, when we say administering this, there's 3 different ways that we can administer it, whether it be going in through a PEG tube or whether it be going in through a nasogastric tube, okay? So these apply to both types of tubes. The syringe, you take the end of a 60 ml syringe and insert it into the opening of the patient's feeding tube, and then you pour the formula into the syringe and let gravity take it into the stomach. With that being said, we need to make sure that this patient's head of the bed is elevated 30 to 45 degrees because we don't want this feeding running out of their stomach and back up their throat and possibly getting into their lungs. So making sure that that patient's head of the bed is elevated and we've checked placement is also important. But this is gravity. We use that syringe. We pour the feeding in and let gravity take it in. There's also a feeding bag. The formula is poured into a feeding bag, which is then hung on an IV pole, and then it connects to the tube, and you can adjust how the flow rate and how fast it goes in as well. And then the same with the pump. It's poured into a feeding bag hung on an IV pole, and then it's threaded through a feeding pump, and that controls the flow. With a syringe, the height of how high we hold that syringe controls the flow. So the higher that we hold it and the higher that we get it, the faster that feeding is going to go in. The lower that it is, the slower that it's going to go in. With the feeding bag without the pump, there's a tube or a clamp, and you can take that clamp, that roller ball clamp, and open it up and adjust the flow manually. And then, of course, with the feeding pump, the pump is actually what controls the rate of which the feeding goes in. So we can look here. This is the syringe. So we're pouring this actual solution into the syringe. This is the bag, and then this is the pump. And there's a clamp right here that you can adjust with that bag, with this particular feeding bag, to adjust the flow rate. We want to make sure that we prevent aspiration with enteral feeding. We want to make sure that this patient is in Fowler's or semi-Fowler's position. We need to make sure they're sitting up in that Fowler's or semi-Fowler's while we're feeding, and we need to leave them sitting up for a little while after we feed them, because if we lay them back down flat after immediately filling their stomach up with food, then again we're running that risk of aspiration. So make sure they're sitting up when we feed them, and make sure that we leave them sitting up for a little while after. To prevent aspiration when the nasogastric tube is removed, we need to place the patient in Fowler's position, and we want to ask the patient to hold his breath as you pull the tube out. So when we're removing that tube, we want to sit that patient up, and then we're going to have them hold their breath. Why do we want to have them hold their breath? Because as that tube is passing through through your oral cavity, if they're holding their breath, any feeding that may drip off the end of that tube is not going to go into the lungs. But if they're breathing, they run the risk of sucking that back into their lungs. Question here, which feeding tube is inserted into the small intestine through the small incision? This would be B, the jejunostomy tube. The jejunostomy tube is inserted into the jejunum part of the small intestine through a surgically made opening in the abdomen. The gastrostomy and jejunostomy tube allows for longer periods of feeding. It prevents irritation to the nose and throat, and it's not as easily dislodged. Moving forward, we're going to talk about the schedules for enteral feedings. With a bolus intermittent feeding, the person receives a large amount of formula over a relatively short period, so you just feed them and then you're done. With cyclic feeding, the person receives small amounts of formula constantly for 8 to 12 hours, and then they're disconnected. With intermittent, the person receives a large amount of formula, but is administered over a slightly longer period of time than the bolus. And then with continuing, they receive small amounts for 20 to 24 hours a day, and these guys are using a pump when they receive the continuous. With continuous feeding, the nurse must monitor to make sure that the bag does not empty out. We don't want that pump sitting there running and nothing being in that bag. There's different types of packing for the feeding formulas. They can become in cans, packets, or either ready-to-hang bottles. We just want to make sure before we administer this feeding that we flush the line and prime the line. We don't want a bunch of air going into the stomach because this could potentially gas them up. And again, we've talked about this, the possible complications of enteral feedings, aspiration, them sucking something back into their lungs, healthcare-associated infections like nosocomial infections and HAI, because we are, we're running the risk of compromising their skin integrity. And if we have a PEG tube placed, then we're going directly through the skin, so that's a port of entry for infection. Dehydration, they may not be getting enough water, so we need to report any changes of urinary output, and if we notice their mucous membranes are becoming dry, we need to report this to the nurse, because that feeding that they're getting is not water, okay? So their food is food, and water is water, so that feeding is not water, so we may have to add some more water with our flushes if we think they're becoming dehydrated. So we need to watch for those symptoms and report that to the nurse. And then again, they may have dumping syndrome. They may have really loose stools that may become irritating to their stomach, and then they have extreme bowel movements. So we need to report that. With healthcare-associated infections or nosocomial infections, they can also result from inadequate medical asepsis technique. So we need to make sure that we're cleaning the site good.